Good afternoon, everyone, and welcome. Thank you for joining us. My name is Larry Lind, and I'm delighted to be your moderator for this virtual program on non-invasive methods of cancer detection and monitoring. I am a professor and the Dean Pro Tem in the UBC Faculty of Pharmaceutical Sciences, and also a proud UBC alum from the School of Population and Public Health. For today's event, we're using live captioning to ensure the event is more accessible and inclusive. So please look to the bottom of your Zoom window for the Show Captions button, where you'll have the option to turn it on and off according to your preference. If at any point during the webinar you experience any audio or video issues, please reach out via the chat and a staff member will be in touch with you to hopefully help resolve the problems. I am privileged to work on UBC's Vancouver campus, and I respectfully acknowledge that it is situated on a traditional, ancestral, unceded territory of the Musqueam people. UBC's Okanagan campus is situated on the traditional, ancestral, unceded territory of the Silks people, Okanagan Nation. I would also like to recognize the many places near and far that you are joining us from and acknowledge the traditional owners and caretakers of those lands. To learn more about the land on which you sit, I recommend the resource nativeland.ca. By acknowledging the traditional owners of these lands, we remind ourselves that Canada's legacy of colonization continues in the present, and that all of us have an obligation to advance reconciliation and decolonization in this country. The UBC Respectful Environment Statement provides the guiding principles to support us in building a setting in which respect, civility, diversity, opportunity, and inclusion are valued. On behalf of the UBC Faculty of Pharmaceutical Sciences, I'd like to extend a warm welcome and thank you in advance for helping to create a respectful and inclusive environment for your fellow alumni, our guests, and speakers. Forward, the campaign for UBC is the biggest fundraising and alumni engagement campaign in UBC's history. With the support of alumni, donors, and friends like all of us joining today, UBC is advancing healthy lives, a healthy planet, and healthy societies while addressing the immediate affordability needs of UBC students. Today's topic is representative of one of the many ways UBC is undertaking research to help create healthier lives. The Innovative Thinkers webinar series is part of the faculty's alumni programming created to highlight our researchers, faculty, and alumni from the UBC Faculty of Pharmaceutical Sciences. The faculty's vision is to be a catalyst for change in pharmacy practice and pharmaceutical sciences. Our goal as innovators in pharmacy education, research, and practice is to support the optimization of drug delivery in the pursuit of improved patient outcomes. We are so thrilled to have you all here today with us for the second webinar in our Innovative Thinkers webinar series. In just a few moments, I will introduce Dr. Carla Williams, who will begin with a short presentation, and following that, we'll be starting off a conversation by asking Carla a few questions, and then I will address questions from all of you in our audience. I'd now like to introduce our fantastic speaker for today. Let's go ahead and have Dr. Williams join me on the screen, please. Thanks, Carla.
Thanks. Thank you, Dr. Lind. I'm very excited to be here today.
So Dr. Williams' research program is focused on cancer metastases and the development of evidence-based medicine for non-invasive methods of cancer detection and monitoring. Dr. Williams studies the cellular and molecular mechanisms driving tumor cell metastases and is exploring the use of extracellular vesicles to help detect and diagnose cancer. The overall goal of Dr. Williams' research is to enhance our understanding of tumor cell metastases, identify and validate potential therapeutic targets, and develop non-invasive biomarker-based tests to improve the clinical management of cancer. And interestingly, Carla and I actually have a collaborative research project looking at some of the biomarkers that she is working on in prostate cancer. So Who would have ever thought a basic scientist working on biomarkers could collaborate with an epidemiologist and health economist? But it's turned into a great project. So with that, welcome, Dr. Williams. One more thing I neglected to mention, our use of Slido today for questions. We will be using Slido today. So please go to the website, go to slido.com. And today our event code is cancer. And you can use that to sign in. Then you can submit your own questions and vote up other questions that you would like to see answered.
Great, thank you. So what I'm hoping to do today is really break down what Dr. Lynn introduced as my research platform here at UBC. And so I'm very happy to be here today to be talking about some of the work that is being undertaken in my program of research, where we're really focused on the study of breast cancer. Breast cancer, people hear about it all the time, and that's because it is unfortunately a fairly common disease. The average female in Canada is looking at a lifetime risk of about incidence of about 1 in 8. So 1 in 8 females are expected at some point in their life to be diagnosed with breast cancer. So that really means that most of us will either be directly or indirectly impacted through a diagnosis of breast cancer. And that's highlighted here just with, you can see within Canada alone, we're looking at about 29,000 new cases of breast cancer being diagnosed each year. And worldwide, this number is dramatically larger, with 2.3 million people being diagnosed worldwide. Now, breast cancer represents 15 to 20% of all cancer cases diagnosed. And this, in 2020, female breast cancer surpassed lung cancer as the most commonly diagnosed cancer. And that was the first time this happened. So breast cancer is the most commonly diagnosed cancer. And it continues to do so. We're seeing this every year, that breast cancer is ranked as the #1 diagnosed cancer. And as you can imagine, since this is shared by the female population, males do develop breast cancer, but only about 1% of cases are male. We have a large proportion of the cancer cases being attributed in the female population. Now, sometimes people think of cancer as being a age-related process, which it is to a certain extent, and people often think of breast cancer as developing in an older population. And what you'll see is that while that is true to the extent where the majority of breast cancer cases are diagnosed in females who are 50 years of age and older, what we will note is that there is still over 16% of breast cancer cases that are diagnosed within younger females, within the age of 30 to 49. And so this is a big concern, because these individuals are not even recommended for the current screening practices that we do employ, which is mammography. So there's areas where we need to improve with how we detect breast cancer on many levels, to improve how we detect, and also to generate detection strategies that are going to allow for early stage detection within this younger population as well. And now, for breast cancer, what we see is that about 15% of individuals who are diagnosed with breast cancer will succumb to their disease. And that's noted here with the average death rate. About 5,000 individuals will succumb to their disease every year in Canada. That number is substantially larger worldwide, at 0.7 million individuals. This is also a higher rate worldwide, with about 25% of individuals diagnosed with breast cancer ending up dying from their disease. And so this is what my research group is really interested in. We're interested in how can we reduce these numbers? How can we make an impact and improve survival of people who are diagnosed with breast cancer? And so one way that we look to do this is by addressing the question of what is the primary cause of patient death. And so the primary cause of patient death is metastasis. So individuals don't die from the lump within their breast. What happens is we have the tumor growing within the breast, and we have cells of the tumor that leave. So they disseminate and they invade locally into this area, and they can get access into the bloodstream. And so when they do this, it's a process of intravasation. They move into the bloodstream. And what happens is that they can extravasate. They can move out of the bloodstream and they can go into distant organs. And when they get into these organs, they can start growing. And the problem arises when the growth becomes so rapid that they take over the organ, and then that organ can't function, and an individual succumbs to their disease. So what we do know is that this process, it happens during tumor development. And so the idea is that the longer this tumor grows, the more cells have the potential to make this process. It's not an easy process. A lot of cells will die in this process. So the one thing that we consider is that if we are looking at implementing strategies to try and reduce metastasis, is that early stage detection could be really important for this. And it is highlighted by data that we have where we know someone is diagnosed with what's called an early stage breast cancer. So it's a very small tumor. Their 5-year survival is excellent at about 98%. Now, if that tumor continues to grow and isn't detected early, that means that there's more time for these cells to start moving around the body. And we can see that that directly impacts survival with advanced stage breast cancer. So individuals that have larger tumors, and perhaps they've moved into some of the local lymph nodes as well, that these individuals have a 5-year survival of 86%. And then unfortunately, individuals who present with disease that's already spread into other organs, they have a 5-year survival of around 31%. So this is where the idea of early detection comes into play, with the idea that if we can detect these very early stage tumors, that people can get treatment for them as soon as possible. And that's going to reduce the chance that cells are going to leave and they're going to move throughout the body and they're going to start growing somewhere else. So when that happens, it's really hard to treat those lesions. And so the idea here is that we can potentially get information from the blood. So if the tumor is really small, imaging strategies are going to be really difficult to detect it. But these tumor cells that are growing, they're constantly releasing small molecules into their environment. And these molecules can end up in the bloodstream. And there's a few ones I've just highlighted here, that proteins, nucleic acids, and circulating tumor cells. These cells also release small particles called extracellular vesicles. And this is what my group is really interested in. We're interested in these small particles. So it's a lipid bilayer, and it contains proteins, nucleic acids, various other molecules that resemble the cell that it came from. So the idea here is that if we can find these in the blood, we can perhaps find some information about the cells that are in the body. This can then lead to potentially being able to identify these very small lesions before they grow any bigger. And so my group has worked on various methods to detect these extracellular vesicles, these small particles. And we've also been working on isolation strategies to isolate them. And so I'll just highlight one of the projects that we have done, where a postdoctoral fellow in the lab, Dr. Nikki Selmond, she worked to isolate extracellular vesicles from clinical samples using either blood plasma from healthy individuals or blood plasma from individuals that were diagnosed with early stage breast cancer, because this is the stage where we want to be able to detect early small lesions. And then these extracellular vesicles were extracted, and then we looked at the different proteins that they contain to say, can we find different proteins in these particles in a individual with early stage cancer. And our results from that, what we found is that we were starting to develop this, it's essentially kind of a fingerprint. And that's what's shown here. So here you can see that each going across here represents a protein, and the color represents the expression of that protein. So blue is low expression, and then red means that there's a lot of expression. And so we have our breast cancer individuals here, and then we have our healthy individuals here. And what you can start to see is that from this project, we started to develop what looks like a fingerprint, where we can distinguish these early stage individuals from our healthy stage individuals. You can see, obviously, this is not perfect yet. Dr. Selman is working on validating some of these markers, but we also think that we can improve on this, because you can see that we are still missing some people who aren't showing up here, and that looks as though they would be healthy compared to these people over here. And so we're looking at improving, developing new ways that we can isolate these, because you can imagine it's blood, it's plasma, there's a lot of particles in here. So we want to really clean things up so that we're really just seeing these extracellular vesicles, because we think that they are important and they contain important information. And that information is going to lead to us being able to develop a fingerprint where we can have a really good ability to actually detect and say someone has very early stage breast cancer. And so our hope with this is that we'll essentially, through this liquid biopsy development, be able to eliminate the presentation of these stages. And we'll be able to have people who are presenting with breast cancer fall primarily within this early stage, very treatable setting. Now, the other aspect of the lab is that we also understand that even if we can try and move and shift the breast cancer landscape to this very early stage position, that we are still going to have people that will present with metastatic disease. Either de novo, they walk in and they're diagnosed with metastatic disease right away, or people who present with metastatic disease after they've undergone treatment. And so to deal with that, we are really interested in looking at developing treatments for metastatic disease. And to do this, we really need to have an improved understanding of this process. So this process that I talked about where the cells can move, they can leave the tumor, they can move through the bloodstream, and they can set up in other organs. This is a difficult process to study, but it's an important process to study, because we really think that stage events are important in that initial growth. And we think that potentially this is also a very vulnerable stage within this very early growth, something that we can target. But if we want to target it, we have to understand how it actually happens. And so my research group, we employ a couple of different models to really help us to actually understand and to watch this process, with the idea that we can identify proteins or sugars that regulate these steps. And then we can work collaboratively with chemists and other scientists to try and think about how we could potentially develop inhibitors for these pathways. And so what I'm going to show you here is just some of that, where we have a model where we use a chicken egg. And that model, we run a few different assays with that model. And what I'm highlighting here is how it really allows us to watch this whole process. So here you can see on the animated diagram, we have a tumor cell that has moved into a blood vessel. And here with this model we can actually monitor these tumor cells as they move in the blood vessel. So this green thing here, this is a tumor cell, and it's in this capillary bed. And so we can watch them move around in this capillary bed. We can then also watch them as they move out. So we can watch this process as they move out into the surrounding space, and they get out of the capillary bed, they move into a new tissue, and then we can watch them as they start to grow in that tissue as well. And we can look at these early stage lesions and we can see what we can do about trying to prevent their growth. And so this is a great platform for us that we run. We use this chicken egg platform for other to also hopefully be looking at personalized medicine as well at some point in time, but I don't really have time to go over that today, but it is an interesting aspect of our research group as well. So I'm just going to highlight a couple stories that we have from this, where what we've been doing is we've been using the models that we have, and we've been looking at molecules that we think are regulating the process of metastasis. Because an interesting aspect of breast cancer is that breast cancer cells like to go to certain organs. And so this is termed organotropism, where we know that some breast cancer cells like to grow in the brain, some like to grow in the liver, some like to grow in the lung, and some like to grow in the bone. Breast cancer definitely has a propensity for growth within the bone. And so we think that there's different molecules that are within these environments that support the tumors, the tumor growth within these areas. And we think that if we can identify these molecules, then we can use our models that we have to see what happens if we stop the cells from having access to those molecules. Can we then stop them from proliferating, and will that then eventually cause them to apoptose and die? And we've published some of this work in terms of looking at breast cancer cells that like to go to the brain. And we've found that there are some molecules within the brain microenvironment that promote a tumor cell dissemination into the brain. And in particular, we identified a neurotransmitter that led to an increase in tumor cell movement into the brain. And then what we've been doing with that is trying to understand how this neurotransmitter, this molecule that's in the brain, how it acts on the tumor cells to promote their movement into the brain, and also to promote their growth within the brain. Because if we can understand if we can understand the basic biology behind how this neurotransmitter is interacting with other proteins on the cell, and how that is then leading to signaling or talking to the cell and leading to cellular proliferation, then we can see if there's actionable targets within this pathway that we can we can identify and that we can also target. And we've had some interesting results coming out of this project. This is led by a PhD student in the lab, Esther. And one of the really cool things that we've found out recently is that this system with this neurotransmitter acting on the tumor cells is actually initiating or stimulating an oncogenic, so a cancer driver pathway. And we're really interested in this pathway, and we are working collaboratively with other individuals within the faculty, with Dr. Brent Page, in terms of small molecules or therapeutics that we can use to actually target this pathway. So we're really excited about the progress of this. And now we do other similar projects within the lab as well. And we have one where we're looking at different molecules within the bone, because the tumor cells, they have a propensity for going to the bone. And when they're there, they kind of chew up the structure, the support, the skeleton. And so we're looking at how this happens, and we're looking at what molecules are in that structure that may be promoting this. And so we've identified a molecule that we're interested in, and we're looking at studying how the same thing, and as I mentioned in the other study, how the tumor cells interact with this molecule, and how that leads to them establishing and growing within the bone. And hopefully from this project, we'll also be able to, one, determine how this is happening, and then be able to identify some actionable targets for this. So this is a general overview of my research program here. We're really focused on liquid biopsy development, with the understanding that, no matter how early we detect, we still need to have our focus also on treatment of metastatic disease. And also particularly for individuals who are currently living with metastatic disease. New treatments coming forward are really important, as well as personalized medicine platforms to try and improve treatment of people currently living with metastatic disease. And so with that, I would really like to thank everyone who signed up to show up today and listen to a little bit about the research that's taking place in my lab. I would like to acknowledge that the land on which my team works here within the Faculty of Pharmaceutical Sciences on the traditional ancestral and unceded territory of the Musqueam people. I'm very privileged to work here. I'm also very privileged to work with such an excellent team. The members of the Williams Lab are all outstanding graduate students and scientists that really make these projects possible. And the other people that I'm really grateful for as well are breast cancer patients involved with the team. So breast cancer patient advocates who are involved with our research projects, who contribute their perspective, their lived experience, and most importantly, their time, because their time is really important. And so the fact that they are willing to come into a research space to provide their perspective and help us with our projects is just phenomenal. And then obviously there's the funding for this work, which is from government and nonprofit organizations. So hopefully that gives people a nice overview of some of the projects in the lab and how we're trying to, trying to implement strategies to reduce the number of deaths associated with a cancer diagnosis. Thank you.
Thank you very much, Carla, for an absolutely outstanding presentation. You know, the epidemiologist in me, it never ceases to amaze me. So many of the tests we use in healthcare they're not perfect tests. So, you know, the opportunities to improve on the testing strategies, I think are so important, and that just speaks to the work that you're doing, and you know, the work that we're doing in prostate cancer screening and PSA, I think is excellent. And you know, when I see these presentations, it never ceases to amaze me, and it boggles my mind, not being a basic science, what we can actually see at the cellular level. And really witness what's going on and what we might be able to impact. Just a reminder for everybody, please go to slido.com, use the code CANCER. Please put your questions, either put your questions up or vote for questions are there, and you can vote them to the top. You can do it from a web browser, you can do it from your phone, whatever's convenient, and I'll certainly monitor those. So, Carla, what's interesting in talking about biomarkers and the direction, and you know, there's so many places as a scientist that you could work. Can you talk a little bit about the inspiration and the motivation behind what you do, and you know, how you ended up going down this road, and what inspires you to work in this particular area of cancer, and in particular biomarkers?
Mm-hmm. Yeah, no, I'd be happy to share that. I'd say that the inspiration for understanding the cellular functions, I was always very, very interested in the mechanisms of cells in general, and how cells grow and how they respond to different molecules within their environment, and just really basic fundamental science questions. And then I would say that the passion for breast cancer really actually came through the advocacy community. And it was during my postdoc when I had exposure to patient advocates. I had two fantastic mentors that I worked with at Western. Dr. Ann Chambers was hugely involved in the breast cancer advocacy community. And it was really connecting with some of those individuals who were living with the disease, and hearing their stories, and having them provide their insights on the research projects and what they thought was important to them. Was really amazing. It really drove a passion for me for breast cancer research, and has continued to with the people that work with my research program. Just phenomenal individuals, and it drives a passion. I love the cellular and molecular events that are happening, and then the passion to actually try and do or generate something that might be clinically applicable to breast cancer is really there.
Excellent. Thanks, Carla. I'm going to go to Slido for a question, actually from one of my team, who we're working on a project actually to do with colleagues in Montreal who are doing the science, and we're doing the evaluation on better measurement of HER2 in breast cancer. So Yuki's question is exciting research, and breast cancer has multiple subtypes. How does your team, or is your team able to address this issue in the biomarker detection?
Yeah, that's a fantastic question, and such a great question. And that's what we would hope to be able to do, because one thing, as our tests evolve and as they develop, and we get better at pulling out these extracellular vesicles, and we get better at looking at the proteins that are on them, we can start to ask questions about tumor heterogeneity, because we know that you can take a breast tumor, and when the pathologist looks at different regions of the tumor, they look at a few, but they don't look at all of it. So in terms of biomarker expression within there, so in terms of HER2, potentially there could be regions within that tumor that are positive that maybe are potentially being missed, because you can't look at every cell in there. You can't have the pathologist spend all that time to look at every cell in there. And so that's the advantage of liquid biopsy. That's where that comes in, is that we should be able to get kind of a representative overview of the entire tumor by looking at these particles. And the other important place that this comes into play is when we talk about metastatic disease, generally the subtype that someone has in their primary tumor is reflected in the metastatic disease, but not always. So sometimes you can have someone who's HER2 negative in the primary tumor, and their metastatic disease can actually be HER2 positive. And so that completely changes the treatment options for that individual, and important treatment options, because the development of antibodies targeting HER2 was just phenomenal for the breast cancer community, and its implementation in the early 2000s was just, it dramatically increased patient survival. So if we can, that's another aspect that we're interested in, is the idea that, you can do patient monitoring, or maybe if someone presents with metastatic disease, you could try and get some information about markers that their disease has, so that you could really tailor treatment. And, I think that's where we're heading, personalized medicine. So.
Yeah, absolutely. I couldn't agree more. And I think, that's exactly what the project that Yuki is working on, who asked the question, is trying to more accurately quantitate the HER2. So you can imagine if you were able to have a biomarker where you could, identify them earlier and then more accurately measure HER2, think of the potential impact in the outcomes over the long run. A really good question here. Cheryl says, thank you so much for sharing. Thinking about more and more trying to integrate patients into our research teams and what role they can play. So the question, how can patients or people with lived experience connect and possibly work within a research program like yours?
Yeah, so I have to say, for the people that I've connected with, it's really been through various breast cancer organizations. So there's the Rethink Breast Cancer. I think that there's also groups with BC Cancer that sign up through BC Cancer, and if they're interested in advocacy. And often patient advocates know other advocates or other people that are interested in being engaged in research. So I think we could maybe use some improvement in our organizational structure of this system, in terms of, if you're someone who's passionate and wants to get involved with research, how would you connect? And so maybe setting up some clearer structure would be nice to have. I kind of walked into that in my postdoc with having someone who was already connected with the advocacy community, and then that connection just stayed in place. I think probably setting up some better lines for engagement of patient advocates with researchers would be great. There's also the Canadian Cancer Conference that's held every 2 years. They have a patient involvement program where people who are interested in patient advocacy can sign up for that program, and then they get to meet researchers and they get to hear about the research that's undergoing. So there are some programs across the country, and then obviously there's local ones as well.
Thanks. And maybe a linking to patients. Again, a really good question. And I was thinking the same thing, and we've done some of this with your PSA biomarker, but just a question around maybe discussing the validation process of your biomarker work. How do you do it, and how could it be improved to increases the chance of really that translational medicine piece of moving from your lab to the bedside to practice?
Mm-hmm. Yeah, so from that initial screen that I showed you, we are working on validating those markers, and so far it's coming along quite well. I think that we need to have better methods to get pure products extracted from blood, and I think that is going to give us a better profile of the proteins that are there, and that's going to allow us to increase our sensitivity of the test. And so we are working on that in terms of trying to develop improved methods of being able to extract these small particles, these extracellular vesicles from blood, because I think that then we'll be able to add in additional biomarkers that have better sensitivity in terms of really distinguishing a healthy individual from an individual who has breast cancer.
This leads to again, a nice segue into my next question, and I have to ask this question as I'm thinking about it. And you're looking at developing a test for early detection, which is obviously what we need, and that's spectacular. And we know, I think standard of care is mammogram, and there's an ongoing debate, and I think it differs across provinces about eligibility at 50 and eligibility at 40, and based on family history, and eligibility less than 40. How do you potentially see this changing practice for detection?
Yeah, I mean, on multiple levels, because I mean, once we have something that we think is implementable, we want to initially run it alongside mammography to show that we can detect just as well, hopefully better. But I mean, that's a really good point in terms of our current screening practices. So mammography, the recommendations are 50 and older. The question is also, should they be 50 or older? Should we be having our younger population undergo mammography screening in their 40s? And so the one thing that I think would be, it'd definitely be a big game changer is if we had a non-invasive test that we could easily implement in a setting so that someone could just simply go and get their blood taken, and they could then look for these markers. And that would then, we'd be hoping for a platform that's more cost effective, so you don't have to have these screening facilities. Another thing that's important is access. Right? We talk about our communities across the province. We talk about our communities across Canada. Access to mammography is another point of consideration in terms of who's actually accessing it. Depending on where you live, how difficult is it for you to access the current screening programs? And so by having a screening program that is a simple blood draw, which, depending on what province you're in, even a pharmacist, pharmacy practice is hugely expanding in terms of what a pharmacist can do. If you have a pharmacist in your local community, they could administer a blood draw. They could send that off to a testing facility, and then they could get a report back, and they could follow up with next steps on what should this person do in terms of follow-up and doing a more thorough, the higher end imaging that they can do to detect the smaller lesions. So, and the important thing would be to get that population, right? The 16% that is within the age of the 30 to 50, right? Those people are definitely, as current screening practices, they're being left behind.
Yeah, and certainly, thinking about, like you say, mammography as our current gold standard, maybe being able to detect the presence of a tumor before it's actually even detectable by mammography, because we know the false negative rate early is an issue. A question from Slido, and maybe this relates to some of the generalizability of your work. A question of Are the extracellular vesicles related to malignant cells in general or specific to breast cancer cells? And again, like I said, maybe speak
Yeah.
to the potential generalizability and broader application to what you're doing.
Yeah, that's a great question. So extracellular vesicles are released by virtually every cell type within the body. So what we find is that the composition of the extracellular vesicles changes, because in your healthy cell, you're going to have your healthy subset of proteins and controlled cell division. And so they're going to be releasing extracellular vesicles and communicating to the cells that are next to them. And those packages are going to contain essentially all markers of a healthy cell. Now, with a malignant cell or a breast cancer cell, you're going to be looking at dramatic changes to the protein profile. So the proteins that are in there, the glycans, so the sugars that are on these proteins, all of this is going to shift. And all of those changes should be represented to some extent in the extracellular vesicles that the malignant cell releases. And that's why we think that they're powerful tools to actually come up with biomarkers for malignant, for breast cancer.
Okay, great. Cheryl had a second question here, and she's heard that ctDNA is a non-invasive marker as well, and is wondering if there's some relation to your team's work, to your team's research, or is it related at all?
So we aren't right now actively pursuing any ctDNA. Once again, there's nucleic acids within the extracellular vesicles, so there is potential for running a study where when we extract the extracellular vesicles, we could look at the nucleic acids that are in them and see if that improves the sensitivity or the specificity of the test, for sure. So there's definitely ways that we could incorporate that in, but as cell-free DNA has been great for certain applications. We've seen that with lung cancer in terms of looking at EGFR mutations. We haven't really seen it yet in a diagnostic setting yet, though.
Okay. Putting my dean's hat on now, again, really interested to see some of the collaborative work that you're doing with Brent. And interesting that you're working at both ends of the spectrum. You're working on the early detection from the biomarkers side, and then at the metastasis, looking at potential drug targets to treat the metastases. Can you expand a little more around the collaboration and kind of the excitement at the treatment end as opposed to the diagnostic end?
Yeah. So I mean, the collaborative work is always fantastic, and the excitement is great because I come up with or I find something of interest in terms of the pathway, and we've got this potential target, and then I know that a couple doors down, this person's working on this or on this family of proteins, and so just a conversation about where they're at and what they have, and then the ability just to scoop up one of their molecules and put it in our system and see how it works, and then the excitement on the other end, where then we show Dr. Page some of the things, and he's just amazed with what we're seeing. It's a lot of fun. So the collaborations are great and really important for research. And I neglected to actually mention, which is on me, about another important collaboration that I have, which is with Dr. Peter Watson. And he's the one who, because of him, we were able to run the early breast cancer panel, because he's a clinical pathologist. And so that's just another thing that highlights the importance of collaborations, because access to clinical samples and so forth, you need collaborations with clinicians for that, and the ability to actually collect those cohorts. So really, another important part of science is collaborations, and I think that drives some of the best research.
Absolutely. I was thinking that as you were presenting, is having access to those pathology samples to do what you do is critical. And of course, another question from Slido. We're all patients in some way, shape, or form, and as we get older, we're more likely to be patients and encounter the healthcare system sooner and be more likely to develop some of these things that we're trying to find. So, and we want better sooner. What do you see as the timeline? Where in a perfect world could you see your early biomarker technology coming into clinical practice?
In a perfect world, we would rapidly implement this new strategy that Dr. Selman in the lab is working on that we think has great potential. And we would rapidly run more samples and come up with an improved fingerprint, in a year or so, and then look at validating some of those, and then look at a side-by-side trial with mammography in 2 to 3 years. That would be an aggressive timeline.
But I'm sure given that it works and it does look like it benefits the population, I think aggressive is good. A question, and you talked a little bit about this, Carla. I think in terms of screening, access to care. I think you touched on it a little bit. A question around, does your research in breast cancer take into account the elements of equity, diversity, and inclusion?
Yeah, and that's really important. And I think that's the idea about having something simpler, something that doesn't require someone to go to a facility that has advanced imaging unless they actually need to go. So the simplicity of a test where anyone can access a blood draw in their local community leads to the majority of communities being able to access a test that does that. And so that's really important for remote communities. And for underserved communities. I mean, not so much in Canada because of our healthcare system, but in the States, when you think about the costs of tests and who has access based on income status and so forth, then that's also another point of consideration as well. When we talk about higher rates of breast cancer diagnosis within let's say the African American population stuff, there's concerns over how much of that is access to healthcare resources. And so really implementing something that is simple, that can be done like at a local pharmacy, so that communities are going to have access to these is really important. And I mean, and that's another great thing about the particles that we look at is they're very stable. So these tests could be done anywhere in Canada, and they could be shipped to a facility without issue about loss of content or so forth, which can be a problem with nucleic acids.
Right. And thinking about that access and the ability to improve the outcomes of those populations that are disproportionately affected by access, that could improve that early diagnosis. I've got a technological question. Being a pharmacist, we're not drawing blood yet, but that may be in the future. Around the technology, do you need a blood draw or could you use a finger prick?
That's a good question. How much do we need? We'd have to assess that. We'd have to figure that out.
Yeah.
Yeah, because that would be very, I mean, in an ideal world, once the markers are there, there's the question of, can you develop a small point of care test platform where essentially what you're saying, you just do a fingerprint, it runs through, and you have something in there that's set up to identify, marker A, B, C, D, and it could run that profile just right there and then. Like that would be the next level of care.
Right. Absolutely. I could see that. We're getting more point of care testing in pharmacies. I think the technology, obviously, for these biomarkers might be a little bit different, but that would be nirvana in terms of early detection, wouldn't it?
Mm-hmm. Yeah.
So thinking about your work specifically, Carla, I know we work in very different areas, and I know what the obstacles I have as an epidemiologist in doing my research and building my research program. What are you finding are your obstacles? I mean, you've talked about a very aggressive timeline, which is really exciting. What do you see as the obstacles in helping you continue to make progress? And what would you need that would help you get to where I think probably most of us on the call would like you to get to is earlier diagnosis and better outcomes with this aggressive timeline?
Yeah, I mean, there's the usual hurdles of research. The research we do is challenging, but outside of that. I mean, everyone deals with that in research. I mean, I think what it comes down to is awareness of the importance of research within the community and the push for research becoming more of an important priority at the government level in terms of access to funds for these types of initiatives. And I mean, I think this type of platform as well, in terms of just increasing awareness to the type of research that's being done in Canada, and so that people really understand what the importance of research and our potential expected outputs, so that there's a push to make science a important platform at a national level, so that we can look at increasing funding essentially to research programs, because you know, we have hurdles in the lab, but we push through them, but you have to have the funding to make sure that comes into play. And unfortunately, Canada's just not, I mean, many of us know that this is researchers, Canada's falling behind in that, and that's unfortunate.
Yes, very unfortunate. So different areas of research, but similar obstacles. For sure. I'm mindful of time. I'm going to ask a really broad question. I see we've cleaned the slate of questions in Slido, and I mean, it's a novel area for me. You're involved in the area. I think you touched on it to say, you know, we're either going to get cancer as an individual, or it's going to affect us in our lives by someone close to us, whether it's a family member or a close friend or what. So in cancer research, we've come such a long way, but there's still such a long way to go. Where do you see the field going in the next 10 years? Say,
Yeah.
Where's the next excitement coming from?
Yeah, so the next excitement, I mean, it's going to be personalized, more personalized approach to treating each individual. And that, you know, it comes with the early detection in terms of having these strategies for early detection for each type of cancer. But then it comes with actually looking at the characteristics of an individual's tumor. And so this comes through the ability to, I mean, we're doing some of this here at UBC, and it's taking tumor samples from metastatic patients and essentially running profiles on them, looking for actionable targets. And so when we're talking about metastatic disease and how we're going to treat it when it presents, right, we need actionable targets now. So the work we're doing is great in terms of identifying new targets, because we hopefully want to identify new actionable targets that maybe are going to have less off-target effects, that are going to improve quality of life for an individual. But we do need we need something sooner than that. And so the thing that could probably be implemented even faster than some of the stuff that we're doing would be that personalized medicine approach, where an individual could have their metastatic tumor taken. They could do profiling on it in terms of the genomic profiling, and they could look for actionable mutations. And then we have various drugs across the board that are used for different types of cancer. And so maybe a breast cancer patient has an actionable mutation that has an approved drug in lung cancer. And so that could potentially be provided. But we do have another hurdle with that, because often when these profiles are done, because these tumor cells are so crazy, they've got so many different mutations in them. And so likely we're not just going to identify 1 or 2 actionable mutations, we're going to identify maybe 5 or more. And so this is where in my group, we're hoping to develop a platform that's going to allow for response to those therapeutics. And I didn't get a chance to talk about it today, but it's using that egg model that I talked about, because we know that patient tumors grow really well on it. And so the idea would be that, you know, essentially some of the tumor goes off to genomics. They look for the actionable mutations. The other pieces of tumor come to my lab. We then grow them on our egg model, and then we treat them with potential drugs based on their mutational profile, and we look for response. And this could all be done in a matter of a couple of weeks, because the model that we have, it's really fast. We get an output really fast for this. And so that would be the, that's where I think that we want to be going, is into that type of an approach. So that someone who's out of options for their standard treatments that they would be given can be provided new options, and not, 5 new options, but potentially 2 that we think actually work based on a measurable response using our model, because we can get that in 2 weeks. It's far superior over the mouse model that people use in terms of trying to grow patient tumors in the mouse model. That takes months and months, and some people don't have months and months. They need something now. And so that's something that I'm looking at getting up and developing within my lab in collaboration with some of the people that are running the genomics screening on tumors. Once again, a collaboration, right?
Exactly. And I think
So
to the personalized medicine approach, as from a health economist perspective, to be able to identify patients who are most likely to respond to a particular therapy, as opposed to trying things where we don't know where they're going to work and then they don't work. That's time and resources foregone that could be used to target the treatment that's most likely to benefit. So that's a great answer. Thanks, Carla. So mindful of time, we're coming to the close of the program. Just give you one last opportunity, Carla, to provide your brief thoughts to the audience. And as we leave, what do you want the audience to take away and think about from this program today?
I guess what I want is for people to walk away positive about the progress that has been made and will continue to be made. We've seen significant improvements in patient outcomes for breast cancer patients because of novel strategies that have been employed. And so while I talk about those statistics and I talk about the death rates, I do want people to walk away positive, thinking that we are going to continue to bring those down. We're going to continue to work, as hard as we can, essentially, to try and improve things for individuals, so that we're going to bring those numbers down. So I'd like people to walk away feeling positive about the future of cancer research, and what we can potentially do in the next few years.
Excellent. I think the advancement in science in this area is absolutely fascinating. So big thank you to Dr. Williams today for a really interesting conversation, and thank you to everyone in the audience for joining the conversation today, and for those of you who posed your great questions in Slido, and for using the technology. I'd also like to invite you to join us for the faculty's upcoming program for alumni and friends, which includes Med Talks on February the 27th at 7 p.m. There's a link in the chat that you can click on to learn more. And just to conclude, this webinar series is created to support Forward, the campaign for UBC, which has a really bold commitment to solve the world's most urgent problems by advancing healthy lives, creating solutions for the planet, and shaping thriving societies. And I think Dr. Williams has spoken very clearly to that today in terms of advancing healthy lives and longevity. And with that, on behalf of the Faculty of Pharmaceutical Sciences, this brings our program today to a close. And thank you again for joining us in the Innovative Thinkers webinar series. I would wish everyone well, and I wish you the best on the rest of your day. Thank you, everyone.
Thank you very much, Dr. Lind.